Hi, ladies and gentlemen. Welcome to this edition of the Cameroon Town Hall for Healthcare Professionals. Once more, we are here after 2 weeks of absence. Glad to see everyone here, regular faces and some new faces in the hall. Last week, we had a very interesting session, and we are sure that this week is going to be exciting as well. We want to thank our presenter who was here with us last week, and is our own chair. He talked to us about COVID-19 updates of therapies that have been granted emergency use authorization, and we all had a really interesting updates as far as COVID-19 is concerned. Remember, it's because of COVID-19 that the Cameroon Town Hall for Healthcare Professionals was founded. So each time we come back to talk about COVID-19, we are excited to get updates from our own chair, who is one of the most updated person as far as this topic is concerned. I call him a trusted authority when it comes to issues of COVID-19 updates, therapies, vaccines, and all that. Today, we shall be having one of the top experts to discuss access to sustainable diagnostic radiology in resource-limited areas. And so he is a trusted authority in this domain too. So
Elvis, please, we have a problem. It's saying registration closed. I think that's why a lot of people cannot get it. So I would have to, I don't know if I should, what I should do about that.
Okay, what I suggest is that if you can ask the people to use the link you send from the Zoom link on your email, which goes to the same people that receive the MailChimp. I also tried, I think from the mail that they received from me, they said registration is closed, but if they use the link that is sent from Muno Kenneth email, I think they'll be able to have access to the meeting. I just tried that.
Okay. Thank you.
So maybe you recommend that they use the email that they receive from you, not the one they receive from me. There should be a technical error. Can we fix that?
I think I just used that too and it didn't work. I'll try, I'll do that.
Okay. That's unfortunate, but we hope that we'll be able to have every other person in the hall. And Brian, nice to meet you today, my co-moderator. I'll be moderating this session with Brian. I got information that Dr. Allison is going to be with us today. I'm sure she's running late. She was supposed to be at the beginning. Let's hope to have Allison. And of course, Louisa Viban is going to be with us. Christelle is also here, so we shall be getting some information in French as well. Our French colleague, Christelle, is here. So Brian, can you say hello to the hall?
Hi, it's really nice to see you after 2 weeks. Hi to everyone and welcome to everyone for joining us. It's really a pleasure to have everyone. We're really looking forward to this very important conversation on radiology and sustainable radiology, diagnostic radiology in Africa. I'm really looking forward to this exchange.
Yeah, thank you so much, Brian. And Christelle is with us. Bonjour, Christelle.
Bonjour Elvis, bonjour tout le monde. Bienvenue à cette édition spéciale Cameroun Town Hall. Désolée, je parle avec ma caméra parce que ma connexion n'est pas très stable. Mais nous souhaitons que chacun participe et gagne le meilleur de la présentation. Merci.
Thank you, Christelle. Since you left Germany and went back to Cameroon, you've been eating the ndole alone. I hope you think about us. We are happy to have you once again. You're welcome to the town hall. Do we have Louisa Viban in the hall? I'm sure she is not yet connected. So ladies and gentlemen, we want to welcome you once again. The number is 20 now. We hope the number is going to increase as many people are having technical issues trying to join the hall. We do hope that we are going to get the numbers. Muno, you want to say hello to the hall? Let's listen to our chair.
Oh, Elvis, thank you very much. I'm trying to make sure that we fix what is going on right now, but I'm truly grateful for Kennedy for accepting to be with us here today. And we go a long way, and he's an expert in what he does. He's actually one of those few people who are based in the diaspora who have gone home. They understand what's going on in their field back home in Cameroon. And during his career, he has tried to make a lot of philanthropic gestures back home to improve radiology and everything that is going on. So I'm really grateful having him here today to be with us for us to discuss this this topic. So Elvis, back to you. And I want to thank everyone else for being here. I'm sorry about the technical issues. I hope I can be able to fix them. We've never had this before, but I'm trying to fix it. So Alison can't join also because of the technical issues going on.
Oh, I see. That's unfortunate. We hope to get them all join us as you'll be working backstage to fix this issue. And of course, some faces in the hall, regular faces, our own Ayok Former, you want to say hello?
Hello, everyone. I am really honored today because Dr. Kennedy, I know him from way back. We were in St. Beats together. I was in high school and they were in the junior section, him and Muno. So I used to take care of them. I was their big sister. And so I'm a proud big sister today, really. I'm so happy seeing him after so many years. Like, you know, I'm really proud. I feel like crying anyways, but you know, I'm so proud of him, really. That's all I can say. And welcome everyone. Thank you.
Thank you so much. Thank you. And now we have Dr. Brown Hilda. You want to say hello to the hall?
Hello, everyone. I'm looking forward to this session today. I think it is really going to be an informative session, especially for those back home. And so I think I'll just sit back, relax, and if I have any questions or contributions, I'll make. Thank you very much.
Oh, thank you so much. I'm so glad to have you, and we are so excited. The number is increasing. As you might have read from my email, I made mention of the fact that we are receiving very positive feedback from those who are watching our session on YouTube, on Facebook, on our website. And that answers the question that most people have always asked, that after all this talking, what next? And the answer is the right people are listening to us. And I think that even those who are in the position of authority to make policy, they are listening to us, and that is very important. As the days go by, you'll be receiving even some government officials on the platform who are coming to also share their voice on some of the issues that we are discussing. That's just to say that the time you take off every fortnight to spend with us here is not all in vain. It's really invaluable. You're doing great work just by being in this hall after 2 weeks to have this conversation. It's a great contribution you are making to Homeland. So I want to say once again, thank you so much. So today we shall be having a conversation on access to a diagnostic radiology in resource limited area by Dr. Kennedy Foyoung, who completed his medical school at Howard University College of Medicine with honors, graduating as a junior member of the Alpha Omega Alpha Honor Society, as well as a member of the Gold Humanism Honor Society. He received a trustee scholarship amongst multiple other awards for academic excellence and humanitarian outreach work. But after medical school, Dr. Foyoung pursued his radiology residency training at Yale New Haven Hospital. During his residency, he made several presentations at national meetings, including winning the RSNA travel grant in 2016 for his presentation. He also co-founded the RAD8 chapter in New York and traveled multiple times to Cameroon, Tanzania to continue radiology outreach work in medium and low resource settings. So he's really a trusted authority when it comes to speaking about access to diagnostic radiology in resource limited setting. He completed a neurology fellowship at Yale New Haven Hospital and is well versed in all aspects of neurology, including advanced imaging applications. He is dedicated to providing the highest quality care to his patients and exceptional service to referring clinicians. So he enjoys traveling, sports, and of course, he likes cooking. I know what a pleasure to have a husband who likes cooking. Thank you so much, Dr. Kennedy, for accepting to be our presenter today. Everyone is excited to listen to you. We know the issues of radiology in Cameroon. At least 1 or 2 persons might have had some challenges trying to gain access to diagnostic radiology. So it is your turn. Take it away from me.
All right, thank you so much, Elvis. It's quite a pleasure to be part of this town hall. I just want to say that it's really an honor to be talking to, people that I've known for years, and they've just taken different positions, and I'm really, privileged to be part of this town hall. And I'm hoping that, by sharing my experience, I could sort of add value to the listeners and make them more informed as to as to which how to provide, care or go back to Cameroon and help improve the conditions. So I'm so happy to be part of this town hall, and happy to have you, and really, really excited to talk about radiology.
Okay, so it's a pleasure. So you can go ahead and share your slide, and we would listen to you, and we'll have the time to ask questions and have a conversation, and that's how we hope to spend this 2 hours with you.
All right, so I'll be talking about improving access to diagnostic radiology in low resource settings. There's a backstory to this topic, and I just want to talk about a conversation I had with the chair, Dr. Former Muna. We talked about his profession. He does oncology, and I do radiology. So we were talking about just how things have evolved and how both our specialties need each other. And he mentioned sort of what I know about Cameroon and improving access to radiology in Cameroon. And I mentioned to him that I did some work volunteering and going back to Cameroon to help with improving radiology access. And he asked me to come to this town hall and talk about just improving access to radiology. So that's why we have this talk. So I have really no disclosures here. I'm a neuroradiologist by training. I also work for this non-for-profit organization called Radiology. So, and that has provided me the opportunity to go back to Cameroon and try to help some health systems with improving access to radiology. So I'll be talking, the talk is overall broken down into 3 parts. Sorry, I may have the wrong slides here, and I apologize. I'm not sure why. Just give me a second. I apologize for that. I had to take out some extra slides just to get the talk concise enough. So, so the talk is broken down into 3 parts. I'll talk about radiology in general, looking at about how our concept of imaging is changing over time. I'll look at what radiology really looks like in Cameroon. So I'm looking at this from the perspective of somebody who was trained here and gone back to Cameroon, trying to help improve things in Cameroon in a certain way. And I'll talk about some of the work I do through RAD8, which is a non-for-profit organization. So I did some projects with 3 different institutions. I worked with Mbingo Baptist Hospital. I did some projects with this whole Plan d'Urgence, and I'll talk about that. And then I'll go out of Cameroon and talk a little bit about a project we did in Tanzania. So, so really, radiology really involves looking at or making diagnoses using imaging. And by imaging, we look at X-rays, ultrasounds, a bunch of other things. We also use nuclear medicine to make diagnoses. And for me, when I'm looking at radiology, I usually would break it down into 2 main groups. I'll look at simple modalities, and I just think these are usually, to break it down, radiology is very capital intensive. So I'm looking at the financial situation, right? So simple modalities are usually cheap modalities you will see, things like plain film and ultrasound. And then we have more advanced modalities, which are more expensive modalities. These are, a lot expensive to acquire. They cost a lot of money, and the hospital really has to make a decision as to why they really want to invest in this modality, because it's expensive to acquire. So I know I know this has been talked about in the town hall, and we know that the World Health Organization says that most of the diseases we see in Cameroon are infectious diseases, right? They are communicable diseases. But I think our thinking about disease has changed over time, right? So we know that we are seeing more long-term diseases. We're seeing a lot of other diseases in our society. And I just put this picture there to show you your typical, Cameroon, you're doing transportation, driving on the highway, and this is sometimes what you would see, right? You see the Benzikin and a bunch of people riding this motorcycle, and what happens when this individual, the head hits the tire, you get this, right? You get hemorrhage in the brain, you get blood in the brain, and ideally you want to have diagnostic imaging sometimes to help our physicians with addressing an issue like this. And to add to that, right, our people are living longer, right? So which is a good thing. We are living more, and with living longer comes another issue, right? We get to see more chronic diseases, we get to see more cancer. And I just want to take the example to talk about breast cancer, right? So breast cancer is one of those diseases which is quite common. So the data says that 1 out of every 8 women will have breast cancer, right? So it's quite common. And unfortunately for us, most of our breast cancer is diagnosed at a late stage, usually at the 3rd or 4th stage of breast cancer. And the survival rates are dismal. You can have about a 30% 5-year survival rate. Now, if you compare that with more developed countries, which would boast a survival rate of about 90 to 82%, you can see a contrast in how this is how we address certain issues in Cameroon. So overall, there's a general acceptance that the way we look at imaging in Cameroon is changing, right? The way we look at diseases is changing, and diagnostic radiology is becoming more important, and it's becoming a priority in our healthcare systems. All right, so one modality I really want to address is the CT scan. Me personally, I feel like a CT is a workhorse imaging we would use in any center that wants to deal with these 3 main disease categories. If you want to deal with trauma, you really need a CT scan. You want to deal with oncology, you really need that CT scan. And then complex surgical care will run a CT scan. So that's why, our overall thinking about this is changing, and our health system is prioritizing imaging in general. So going back to oncology, I don't know, I wanted to ask an oncologist in our, just ask him his take on what he thinks about oncology and imaging, and that multidisciplinary aspect of imaging and oncology. I don't know, Dr. Former, can you address this?
Yes, so I think without imaging, there is no oncology, really. Why? Because we're going to be unable to stage patients. We will be unable to even get tissue. So where there is no tissue, there is no issue, there is no diagnosis of a cancer. So in order for you to diagnose a cancer, you need tissue. There are others who can help us get tissue. At times, the pulmonologists can help us with other techniques. There are the cardiac surgeons can help us, the GI doctors, but it's really multidisciplinary. But the main person who gets us tissues are the interventional radiologists. And without tissue, you're unable to even know what kind of cancer you're dealing with. Without imaging, you're unable to stage your cancer. Without imaging, you're unable to evaluate response to treatment. So it becomes like we cannot do without radiology. We just cannot do without you guys. It's interwoven in the care of patients. So that's I think we'll talk more during the discussion part of the talk.
Yeah, I just want to say, this is the conversation we are having on the side, right? He tells me he needs oncology. I tell him I need him. He needs me. So these 2 specialties need each other to work together, and imaging becomes really important. So one of the things about radiology is that we are so involved with care in other specialties. We use ultrasound. First and second trimester, we work with OBGYNs. We need. Oncologists come to us and ask us to stage disease, to diagnose disease, to give them tissue. We work with the surgeon. Sometimes they have an abscess for us to drain and things like that. So we are so interdependent, right? So these are some of the conversations we are having, and we feel like in a good, properly functioning health system, for instance, what we're trying to achieve in Cameroon, imaging really forms an integral part in making your imaging center, making your health delivery really good. You need imaging. So just looking at how radiology looks in Cameroon today, I want to say that I'll preface this by saying that there's really not a lot of data we don't have a lot of data to help us drive decision making, right? This is something that's been spoken about in our town halls, but it's a need for us to get data as to how many imaging centers we have and how much access people have to imaging. But in general, we think that imaging has been progressively improving over the last 10 years. Most people say that there are about 100 and 150 medical imaging centers. Most of these imaging centers are clustered in the big cities, right? Mostly in Douala and Yaoundé. And most of these imaging centers just have that basic modality. They have X-ray and ultrasound, and they don't have the advanced modalities like CT scan, MRI scan. These are not really readily available. And I also want to show this slide to show an evolution of imaging from, say, 2017 to where we are today. I remember first going back to Cameroon, and I was told that every region, there are 10 regions, every region had some kind of advanced modality. They had some kind of CT in the regional hospital. Unfortunately, that's not always true, but we are having the public sector has its weaknesses, but the private sector is booming, is becoming it's advancing, right? So there are a lot of new private sectors in big cities like Yaoundé and Douala and Bafoussam and some in the Northwest region. So back in 2017, we knew that there were 2 MRI scanners. Sometimes imaging is so nuanced, right? I talk about MRI scanners, and for me, I look at what is called high field MRI and low field MRI. So high field MRI, things like I'm looking at a 1.5 Tesla MRI as opposed to a 0.3 Tesla MRI. So these are completely different. The quality of the images you get is night and day, but the normal person doesn't know that there's a difference, right? So you just go get your imaging. But we know that we don't have a lot of high field MRIs in Cameroon. Things like nuclear medicine are not very available. As far as radiation oncology is concerned, what I know is that we used to have 2 centers in the country. We had one in Yaoundé and one in Douala. I know the one in Yaoundé doesn't work now. I'm not sure. You can correct me if I'm wrong, but just it's not always certain what you get, right? You don't always, the devices don't always work when they say they work. But I want to say that a lot of changing is happening now. We have this quote unquote plan d'urgence, and it's a project by the government to put more machines and to equip hospitals. So this project has led to more imaging in the country. So I know that recently we had 3 angiographic suits, 3 new cardiac cath labs created in the country. We had a few MRI centers created, and then we have other projects, and these projects are sort of, they try to spread them around, but there's still some disparities overall when you look at where the imaging goes. So the thing with imaging is that the unfortunate part about our imaging is that it's not always very sustainable, right? Most of the equipment we have in Cameroon doesn't function at full capacity. They say most of the equipment function at less than 80% capacity. And I've heard numbers like 50% of the equipment don't even function at all. And that's true in some cases. Most of the equipment becomes dysfunctional in the warranty period. And some of the reasons for this is that sometimes we don't have regular maintenance and we don't have maintenance contracts, right? So another thing with imaging is that we work very closely with engineering, right? So, for you to have a functioning imaging center, you need to have good engineers that are going to come and maintain your equipment and make sure that it's working. So, things like imaging breaking down and then not working, and then you have to, fly somebody from abroad to come and fix that equipment, it really makes it difficult for our health system to function. And then the other issue we have in Cameroon is human resources, right? Just in summary, I'll say that we don't have enough people to take care of the volume and variety of disease we have. So these are just approximate numbers from our surveys. We have 1 to about, say, 500,000, 1 radiologist to about 500,000 patients. We have very few radiation oncologists. I can literally count them. They're just so few. And then when it comes to technologies, we have a lack of very trained technologists. Most of the technologists we have don't have the adequate training and education. And some of that is related to the fact that we don't even have the machines to train the technologists on. Sometimes you need to work side by side with another person and work on a machine. But if you don't have the machines, then you cannot have the training. And then when it comes to other things like medical physicists, there are even fewer medical physicists and even fewer medical engineers. So this sort of summarizes what we have, or what I know to be true about imaging in the country. This is obviously data that is dated. This is from 2017. And this is a summary that looks at our human resources and our infrastructure. And I'm just repeating myself, but this is what we know as far as imaging is concerned. So I just wanted to talk about RAD8. This is an NGO I worked for, and I used to work for. One second. Okay. Anyway, RAD8 is a not-for-profit organization that is based in the US, and their goal is to improve radiology in underserved, poor, and developing countries. So mostly what RAD8 has going for them is that they have a pool of volunteers. These are a group of radiologists, radiology technologists, and then nurses. These are all they volunteer to go help out. Usually building capacity or helping train healthcare facilities or helping addressing issues that with access to imaging. I just want to say that since its inception back in 2008, RAD8 has been gaining more and more in volunteers, and I sort of aligned myself with them because they were the only group I know that did volunteer work when it came to imaging in the US. So some of what RAD8 does is that they, usually they'll look at a healthcare system, look for what is missing, and then try to complement that healthcare system to fix or help them fix what is missing or help that system become better. So they use this radiology readiness assessment. This is the model by which RAD8 works. And really what they do is do an analysis of the healthcare system, right? So we look at everything. We look at the infrastructure, you look at power, you look at IT, you look at other specialties, you look at the presence of a lab. You cannot do a biopsy when you don't have a histopathology lab, right? Doesn't make sense. You cannot do a biopsy when you don't have a surgeon to take out the tumor. It doesn't make sense. So certain things that we look at that, you just give guidance to the health system to make sure that they know exactly what it entails to become that health system which is successful. But more important, we sort of help them fill some of the gaps that they need to become a sustainable health system. And so this is what the model RAD8 uses, and it's you go on their website and this is what you get. So I talked about the radiology readiness assessment, which is a survey that you would do usually when you want to help an imaging center, know some of their blind spots and help them become a better center. And we typically do what is called a radiology readiness assessment, and it's very comprehensive. It has everything from the type of diseases that we see, the other specialties that exist in that facility. You look at the things like power, IT, electricity. You look at human resources. You look at the labs, and those those pieces of information will help you sort of guide decision making. Sometimes the hospital may not benefit from having certain modalities. Sometimes they may need certain resources more than others. So this is just a guide as to helping hospitals to optimize their resources to be able to acquire the right type of imaging. So I'll share some of my experiences from just my volunteer work. Some of it is through RAD8, some of it is personal travel, but this is just what I was part of. So I know most people here know Mbingo Baptist Hospital, but this is one of the first projects I got involved in. And Mbingo is a tertiary care center. It's a teaching hospital, and it has a few different specialties. At the time, we knew Mbingo was one of those hospitals that treated a lot of complex surgical disease, usually head and neck disease. And unfortunately, we had the good thing is we had surgeons in Mbingo, and we had some surgeons coming from abroad, but they never really had good imaging to help them with the treatment, right? There was no radiology in Mbingo. So these doctors would get imaging maybe sometimes from the regional hospital, and it's not good imaging. The reports are not always very accurate. Sometimes they're accurate, but not always very accurate. And so this hospital decided that it was time for them to get their own imaging center. To be very honest with you, they had bigger goals, right? The goal was to open up an oncology center, a comprehensive cancer center that had, the full modality, the full suite of oncology care, which involves imaging, involves, medical oncology, radiation oncology, and even surgical oncology. So, so part of what Mbingo did and what we did, we sort of worked in collaboration with them. Is you help them define their strategy to be able to start that imaging center. We could clearly see that they needed an imaging center. You know, they treated a lot of oncological disease. There was the trauma component. They had complex surgery happening, but they needed that imaging. So so most of Bingo acquired a CT scanner, right? This was through funding and loans and grants. Some of the loans came from the company, from Siemens itself. Siemens, you know, helped Bingo with a loan to acquire that machine. And then obviously Bingo has, I think from what I know, they have paid for that machine and it's completely owned by Bingo. So they built this imaging center from scratch, and I can just show you images of them from the initial designs, and then the building coming up, and then finally acquiring this 16 slice CT this Siemens scanner, and you can see that now they have an imaging center. But in addition to just CT, they also acquired a lot of other imaging modalities, which really involved ultrasound and some other imaging modalities. So some of what I would typically do with Bingo was work on that other end, which is capacity building and sort of assisting the hospital in getting the optimal use of that equipment, right? So some of my work was involved with the hiring of an on-site radiologist. I know when Bingo first put that scanner, they didn't have anybody on site. So they did a little bit of teleradiology in the beginning. They had some of the images being interpreted from abroad, but then they were able to acquire a very good radiologist, and I would work in concert with him, sort of helping him train him. And my specialty is neuroradiology, and he's a general radiologist, and I would sort of help him, to better niche down on specific diagnosis. He had access to other entities, but also, we would support him with that component of capacity building. Some of the other things we would do is also just working with the ultrasound technologists. We had sessions where they acquired an ultrasound machine that could do elastography, and they were interested in setting up a center where they could, do some imaging in the setting of hepatitis, and they wanted to know how to use this device to do elastography. So what we did is we were able to link the hospital with somebody who was a specialist in elastography. She works for the company Siemens, and she does training usually for in the US for companies, and she gets paid. But when she's working with Radiology, she does it for free. So she was able to help train some of their staff around doing ultrasound elastography. And then the other thing I want to mention, that one thing that Bingo did in particular was make sure that they're able to provide sustainable imaging, and and that involves usually getting a maintenance contract, right? So you want regular maintenance of your equipment. I just point out that the equipment was acquired through Siemens and through his imaging group, Narosh. He's one of the few people that we know that an engineer that sort of can provide access to maintenance and can fix some of this equipment, because that's a big problem we have with imaging in Cameroon. You just no problems with sustainability. So it's always good to have in-country people that actually have that are savvy enough to be able to fix the devices when they become bad. So I would mention the plan d'urgence and what that entails, and sort of how we worked in collaboration with that whole project. So the plan d'urgence itself is a huge project. It's done from the Cameroon government, and this was done in preparation for the African Nations Cup. And basically what was happening here was the government wanted to revamp the whole healthcare system, and they're building 8 new hospitals, and they're refreshing 3 of the regional hospitals. And this involved a lot of buying of new equipment and installing new equipment. And this, the big project went to a group called Alliance, which is a company that from North Africa, and Alliance did the building, and they gave the equipment part to Siemens, and Siemens works with this person, and we because we worked we had had a know-how from Bingo. We partnered with them to help with capacity building on that end. But overall, this project is bringing in more and more equipment into the country. And these are the first 3 hospitals that were equipped. I mean, there are more projects happening. There are more hospitals that are going to get more equipment. I just wanted to mention this, because that is happening as we speak. And I want to show that some of what we did with Radi was just helping. We've really focused on niche down on training technologists. That's that building that capacity around the imaging equipment. The thing is, sometimes if you don't have a good technologies, you can have not just getting bad imaging or bad diagnosis, but the equipment, you can also destroy the equipment. So it's very important to have a very well-trained technologist to run that equipment, because they really serve as the first, they're the first people that troubleshoot the machine if something goes wrong. And it's really important to have a good trained technologist to be able to run that machine. So this is a picture from one of the meetings we had with, in a combination with other partners, with Siemens and Naroche, and just really talking about that plan d'urgence. And I sort of have everybody's information just to show you that it's really not just one piece, right? You don't have just one radiologist. You have engineering, you have you have applications people, you have IT. There's so many factors that go into just putting up an imaging center. And then I had interactions with Siemens and even with some technologists in Cameroon, and the pictures are there to show that. Then there was a short-term project we did with the plan d'urgence when the very first high-field MRI that was placed in Yaoundé was placed in the military hospital. We did some training around that equipment. We worked with the radiologists with the protocols of getting imaging. Imaging is, when it comes to MRI, it's really complicated. You have to have the right protocols. You have to have the right, there's a lot of things that go into getting you that good imaging to get a good diagnosis. And it's really important that you have the right people working on the machine, and so it, not just the radiologists, but we have a technologist. And so some of the things we did was building capacity around the technologists. So the goal was for us to get more volunteers from Canada, and just because of the language issues, we can get more volunteers to go to Cameroon and work side by side with technologists in Cameroon to build capacity around the equipment. That was the plan. I mean, we had some challenges with this project because we had COVID-19 in the middle of the project, and so travel became a bit of an issue. And then finally, I want to talk about some of the work I did in Tanzania, right? This has to do with interventional radiology, and this was done while I was a resident. And there's a few other actors. I was part of the Rare Radiology Global Outreach Group, part of Radiate, and then there's another group that was formed in the middle of this project called Road to IR, and all these different groups came together to achieve this goal. So what we did in Tanzania is Tanzania never had an interventional radiologist. So I'll just mention that Frank here is was my attending at the time. He's a neuroradiologist as well. He was born in Tanzania, and he went back to his country and started the first radiology residency training program in Tanzania, right? So what he would do is bring in residents from our program, which was Yale at the time, to come to Tanzania and work side by side with his residents. He worked in Yale and worked in Tanzania. And he brought Fabian, who was a resident at the time, and he brought me. And then, so we started, Fabian was into IR. So we'd set, there was no IR in Tanzania. So it's like, let's start from somewhere. So these are the first 3 radiology residents that were chosen to start to go into IR. And I'll sort of tell you what happened from there. So this picture shows the first procedure that we did. This was a CT guided biopsy. And at the time, we didn't have the equipment to do this procedure. We had some needles, but we didn't have what we call a grid. The grid is what we will put on the MRI to tell us where we need to put our needle to get inside the lung and get the biopsy, get the tissue. So Eric, he created a grid for us. And, this is fascinating because this is back then, there was nothing in, radiology was just starting in the country, and he was able to creatively create something that was going to help us with this procedure. So, so I just want to say that this procedure, there was a partnership between MUHAS, which was the training program in Tanzania, Muhimbili University, University Hospital of Health. Sorry, I'm losing but Health and Alliance Sciences, and then this in combination with Yale and Emory, and then in combination with Radiate, and then Road to IR. So the goal was to train residents to provide IR services. And what we had to do was provide training on hands-on procedures, as well as provide training, give them a knowledge base to practice IR. So what we did was get interventional radiology faculty from the United States to travel to Tanzania and provide training to these residents. So what we would do is get faculty from the US to travel to Tanzania for 2 weeks, and work alongside with these residents, give them some training, and then come back, and then we'll do sort of mission trips. And the goal was to get at least 10 mission trips in 1 year. So they were organized in 2 blocks in weeks, in 2-week blocks, and this was supposed to go on for 3 to 5 years. And then the plan was also to get the interventional radiology residents to come to Yale and practice interventional radiology for 3 months. And then once they get to see how the full spectrum of interventional radiology works, they can go back to Tanzania and practice there. So this is a sample of a schedule of what an interventional radiology attending that we recruit that goes to Tanzania is going to see, right? So initially they get picked up from the airport, and then they get oriented with the hospital leadership. On Monday morning, they get to see the residents, they discuss cases, and then they do some cases while they're with the resident, and then they do some resident teaching. On the weekends, they go on a trip to, you had something fun for them to do, and then the next week they did the same thing. They did morning rounds, did some cases, and then they did some resident teaching, and then once they're done, they go back to the US. So this was just sort of shows you what was done to get faculty or very specialists from the US to go down and work with these residents and sort of do that quote unquote skill transfer, right? So in the beginning, the residents had 0 skills, and then the attendings had 100%, and then you put them side by side, and you're hoping that through time you get that 100% to 0, and then you get 80% to 20, and then you get 60% to 40, and then sometime at some point you get 80, and then so you're sort of trying to do that knowledge transfer, and that was the plan for this. So what else we did was do a lot of global lecture sharing. We would stream out all the lectures that we did at the university at Yale, and would have the radiology residents in Tanzania watch those lectures. So they were part of our program. They were part of the interventional radiology program at Yale, and they would see the same lectures that we see. So whenever we go to morning conference, we do a Zoom lecture. We would have the residents in Tanzania also watch the Zoom lectures. And then they were made members of the major organizations in the US, Society of Interventional Radiology and Society of Interventional Oncology. And then, we did, so basically when the attendings came to Tanzania, they did a lot of procedures. Usually the patients would have a month, right? In a month, they'll do a lot of scouting. They'll do 2 weeks of scouting, getting good cases for the attendings to come and do, right? You need volume to train people. You need disease to train people. So you would scout, get the volume, and then once we get the patients ready, the next 2 weeks, the attendings come, and then they work with the residents in doing those cases. So there was a 2 week scouting, 2 weeks of high-yield procedures. And then we made sure that they got some kind of accreditation from the local universities and the National Education Board. And then some of the volunteers came from Radiology, and then some of them were just interventional radiology faculty from the US. So this was broken down to 3 phases. The first phase was doing simple procedures, immediate procedures that immediately needed. The second phase was doing core procedures, right? And then the third phase was doing very complex procedures. And then for that first phase, you had just simple procedures like core needle biopsy, aspiration, and drainage, very simple things, nephrostomy, arthrograms. These are really simple procedures. And then the next phase was doing more complex procedures like gastrostomy, jejunostomy. These are a little bit more complex, IVC filters. And then the final phase will do more vascular procedures, which have a little bit more complexity, a little bit more risk, right? So there's more to this. We have to look at the infrastructure. We have to train some nurses. So there's other components to this. And I'll just show you a sample of the schedule. So believe it or not, we were able to fill this schedule. Mostly Fabian, he was an interventional radiology resident, and he, through combinations from a bunch of universities, we were able to get attendings to travel to Tanzania and do this. And just recently in September of 2021, Tanzania was able to graduate their first set of IR attendings. So the first 3 interventional radiology attendings in Tanzania. So in summary, I just want to point out a few lessons that I've learned along the way, right? The first thing is that we are looking at imaging in general is changing. The concept of health and imaging is changing, right? We are beginning to move from that mindset of just infectious disease and simple medicine to more complex medicine. We're looking more at advanced disease, chronic disease. I don't want to say simple because nothing is simple, but we're beginning to look at the whole spectrum of healthcare, and with that comes the need for more imaging and better access to imaging, right? One thing that we suffer from is just the high failure rate of our equipment. Most of our equipment doesn't perform well, and we have a high failure rate. And we think that just having those partnerships with engineering, being able to maintain this equipment is very critical. You need to have relationships with engineering. And when I speak of relationships with engineering, you need to have local engineers in the country who can, who can make that machine function. Turnover time is important. Downtime for a machine, you lose patience, you lose money, right? So you want to be able to access that engineer to come over in less than a day. So, back in the days, we would have to get somebody from Europe to come and fix the equipment. We're hoping that with time, we can train more engineers who are local to be able to help and fix some of our problems locally. And that decreases downtime, that decreases turnover time. And then the other big piece is working to really train more skilled workforce. And having more skilled workforce is so important to maintain the equipment, to get you good imaging, and to have a sustainable imaging center. So I'm going to stop there. And I think that should be it for this talk. Thank you, guys. Thank you.
Wow. Thank you so much, Dr. Kennedy, for this wonderful presentation. Alison, I'm sure you were able to.
Hi, everyone. I'm so excited to see you all again. Dr. Foyong, this has been interesting. Thank you so much and very enlightening. And for all our viewers, both within the Zoom meeting and viewing us on social media platforms, I hope you're well. I hope your families are well. Just, we're just looking at the COVID numbers and they're rising. So if you have family members who are eligible for the vaccine, who've not been vaccinated yet, please convince them to get this vaccine. And, back to Dr. Foyong's presentation, Doc, thank you so much. We already have a few of our viewers who've been texting me back and forth requesting your email because they want to get in touch. So maybe if you don't mind, you could share your email address with us in the chat. And we do have some people who are wondering whether you're willing to share your slides. So you could always, drop the slides with us if you're willing at the end of the presentation. But we are now going to open it up for the question and answer session. And I was just burning with this question in mind as you were presenting, because a few weeks back, I had a major health scare and I had to be rushed to the ER for an MRI scan. And that was the first time I was getting an MRI scan. Thank God it came back to be something minor. But now the not so cool part of it was that despite me having health insurance, after that I got a bill. And that was a part I did not like because I looked at the bill. It wasn't very big, but it was quite a bit of money for me. I'm a student. I'm like, yeah, this is quite a lot of money. Like how, well, I could pay for that because the health insurance covered the majority. Now, for imaging within our context, so good imaging is expensive. Within our African context, like how do our health systems succeed to balance this issue of cost, considering that for most of our patients, they have to pay out of pocket for imaging?
Okay.
Thank you for that question. And maybe, Doctor, you want to stop sharing your slides so we can have a full screen and have this conversation. It's time for conversation. Good. Thank you. Dr. Foyong, you want to come in for your answer the question?
Sure. So I would say that healthcare cost is not really my forte. It's not something I'm really good at, but so cost issues are difficult to address, right? So the hope is that you have a system where you have some kind of help from a third party. I mean, unfortunately in Cameroon, that is not the case. I know personally that imaging is not cheap in Cameroon. I know for a CT scan, you pay somewhere between 75,000 to I think 150,000. You also have to sometimes pay for your own contrast. So imaging is not cheap. In the big cities, especially for the private sector, they need the money to run the imaging center. So, it's difficult to explain. You kind of have to justify the cost because they need to get money to run their centers. So, I mean, the hope is that this is where you want a system to function, right? You want to be able to have a system where people can have help with third payers and in other ways to subsidize the cost of imaging. Even in the US, there's concerns about over imaging and the cost of imaging. To be very honest with you, I always tell people I don't order any imaging. I just read the images. They still blame us for everything. So I think cost is an issue, and you need help from third parties. You need help from the government. You need the system to work better. But yes, I agree with you. It's very unfortunate that we have issues with cost of imaging.
Yeah.
Okay.
Yeah.
maybe before I just hand over back to you, Elvis, I have one last question that came directly to me from a student who is viewing this presentation, and the student is wondering what your academic journey. The student is like, we know that it was highlighted during the introduction, but how did you get to be where you are? Like, maybe if you can just briefly describe your academic journey.
Right. So I did all of my formative years in Cameroon. I went to high school in Cameroon. When I left high school, I had the opportunity to come to the US, and I went to school in the US. And believe it or not, I started out in a community college. I was lucky enough to have some good grades, and then I transferred to a 4-year institution, had really good grades, and then took an exam called the MCATs to get into medical school. And then when I did my MCATs, I was fortunate enough to get a good scholarship from a university called Howard, and that's where I did my medical training. And then while I was there, I was fortunate enough to be top 5 in my class, and then I got residency at Yale. So that's really my story. It's really I had some fortune along the way, but but it was really just speaking of radiology particularly, it's one of those fields where I never knew about radiology before going to medical school. So once I worked with a radiologist and I saw what they do, and I knew that the kind of impact they had in driving treatment overall, they had to make the diagnosis, and that overall would determine how the patient gets treated. I thought that was a good field for me to go into. And to be honest with you, I never really liked any other field. I couldn't. My surgical skills are not the greatest, so I didn't think that was where I needed to be. So imaging, that's how I ended up in radiology.
So Kennedy is always very humble by saying how he's planned. But Kennedy was actually, he's a very hardworking person, and he was the first in the GC the year he wrote. He had 5 A grades before moving here to the US, and he's been always the guy we are proud of, because he lived up to the expectation. Because at times the most intelligent people in life are never the most successful, because they don't know how to deal with failure. But knowing Kennedy from down back in St. Bede's till now, he's been a shining star everywhere he goes to. So we're proud of you, and young people could take this as an example to work hard. Hard work pays. So
yeah,
hard work truly pays. Christelle, vous avez quelques remarques?
Non, je suis d'accord d'avis avec Dr. Foma. Travail paye, vraiment. Et c'est un appel aussi à notre engagement et d'endurance avec l'exemple du Dr. Foyon. Merci beaucoup pour la présentation. Merci encore.
Thank you so much, Christelle. And Brian?
Yeah, thanks, Elvis. I think it was a really great presentation. Very, very inspiring journey as well. And thanks, Dr. Foyon, for sharing your journey. I think there are also a lot of students on the hall as well, and people trying to decide what kind of medical specialty, for instance, we've been going to, and sometimes making the decision early on is not, it's always not that obvious. And also some people really have difficulties with, dealing with failure, and really sharing that that journey, your journey. I think it's really, very inspirational. And I think radiology is one of those most competitive specialties in the United States to get into, and getting a spot into Yale, even more challenging. I think a lot more people even want to know more about how, how that worked out for you as well as a Black, and dealing with all the other constraints. But back to the topic, I think radiology, really looking forward to this conversation on diagnostic radiology. I mean, personally, I don't really have had any interest in radiology, but I think the importance of radiology was kind of highlighted throughout the COVID-19 pandemic. I mean, at the beginning, late 2019, early 2020, no idea, what this was all about, and just starting with some outbreaks of acute respiratory syndromes, and people were using radiology services just to triage patients that, you know, might be at risk of. And I really would love to get your perspective on that as well, really using that to triage patients that are, you know, at risk of, you know, severe disease outcomes, and especially if you didn't have either you didn't have a PCR test, or you had a PCR, but you just had a very high index of suspicion from a patient's symptomatology and things like that. And I really wanted to hear your thoughts on the just the integration of radiology in just COVID guidelines in general. Because I think when I look at COVID-19 guidelines, particularly from the CDC and the NIH and the World Health Organization, I don't see a lot of, there's no radiology, there's no space for radiology. And I really wanted to get your thoughts on that. The second thing I really wanted you to address as well, I think Alison kind of talked a little bit about that, the cost of radiology. I'm really thinking about Africa as a whole and the challenges that we have to go through. I heard you saying the cost for a CT scan is about 150,000 francs in Cameroon. I don't know what that is in US dollars, but imagine that I had like just an appendicitis and I had to do an appendectomy. I know there are some surgeons on the call here, but the cost of doing an appendectomy can sometimes be just an exploratory surgery or an exploratory laparotomy, you know, it's even less than the cost of the CT scan that you mentioned. I don't know how much the cost of an MRI is, but just the around cost and, you know, exploratory surgery or exploratory laparotomy, I really wanted to get your thoughts on that as well. And what are some sustainable solutions to these, you know, challenges of radiology, expanding radiology care in Africa and things around that nature as well. And the third thing, and just the last thing, sorry, I know they're not supposed to ask more than 2 questions, but the challenge of really the future of telemedicine in general, I hear there's just a lot of promise you really using radiology services from across the world and just bringing radiologists together, and the challenges that Africa poses. You know, we have, I don't know if just not having steady electrical supply in Cameroon is one of the reasons why our equipments are always, you know, being damaged and constantly needing repairs. Are there more sustainable solutions to this problem? And yeah, that's it.
So thank you so much for those questions. Those are really insightful questions. I want to take the first question, which is integration of radiology into the COVID guidelines. You know, radiology, I don't think has a huge role in the COVID guidelines, right? I think that, you know, most of the findings we see in radiological data usually lags behind laboratory findings, right? So I think that PCR test or that COVID test is a cheaper test and more accurate test for making that diagnosis. Now, when we look at complications of COVID, right, if you have a patient that has complications of COVID, sometimes radiology could be important in helping to guide treatment in that setting. Now, we do see some findings in COVID. We sometimes would see these ground glass opacities that have a peripheral distribution. We see that on CT. In a rare case, that could be, you know, you could have a patient that gets misdiagnosed, you know, that doesn't have the right diagnosis, and then we would be reading a random CT scan and you can see that on CT. But usually, radiology doesn't serve a very strong purpose in the care of a COVID patient. I think the laboratory diagnosis is the way to go. And then you spoke about cost. Cost of imaging is, you know, it's an issue that really, I mean, it's tough to answer. You know, the hope is just being able to decrease costs by, I guess, maybe helping to subsidize imaging and you know, it's an ongoing issue. I'm not particularly sure how to best address this, but you know, you're hoping that you can get more folks, you know, can get insurance systems to help cover the cost, and you know, I guess yeah, it's just one of those things where the cost sort of transfers from getting the equipment there, paying for the services, and you know, you hope that cost can be subsidized in one way or another. And then the third thing you talked about is future of telemedicine and the challenges of telemedicine. So telemedicine is a tricky topic, right? we talk about telemedicine a lot, and I'm very careful when I talk about telemedicine, because sometimes we've had situations where in countries that are developing radiology, for instance, in Nigeria, you get images being sent to India and they get read by the Indian doctors, and then the Nigerian doctors in country they get bypassed, right? They don't get training, they don't get, this is so some of those things happen, right? So for me, I always see that it's important that the in-country doctor has control over the imaging. And for me, I would see teleradiology as a way to either complement a system or help train somebody. But reading those images abroad usually doesn't do good when it comes to sustainability, because you don't train the local doctors, and you're not able to, how can I put it? The system is not sustainable, and that's unfortunately the case. But radiology has its pluses and minuses. We have a very globalized system. Everything is digitalized. I talk a lot about PACS in some of my my presentations, because PACS, you can get these images converted into a format called DICOM, and you can send them to anywhere in the world. You can get wherever to read them. And in some cases, when we have hospitals that have severe shortages, we can, read those. You have hospitals helping to carry some of that load, and you have situations where some hospitals just don't trust their doctors and they send those images abroad. But those issues are, not. Yeah, it's a very slippery slope, right? You want to make sure that, the in-country people that see these images are able to make those diagnoses, because sometimes they can offer treatment, and they're in country, and you want to build that capacity in country. So I have mixed responses when it comes to telemedicine, to teleradiology.
Thank you so much for those answers, and we would now get to the hall. We always have the opportunity for co-moderators to ask their questions, and the advantage of co-moderating is that you can ask many questions. So Brian, don't worry. We thank you for those questions. They were very useful. We have Carson Asagawe. Please, it's your turn, and you can always tell us where you are dialing in from, just so we always have a scope of where the members are coming from.
Hi, good evening to everyone. And thanks, Dr. Kennedy, for the brilliant lecture. It's Carlson from Jerusalem in Israel. So shalom. It's good evening for me, but it's going to be good evening and good morning to all of you. Thanks once more for the lecture, Dr. Kennedy. I must say, I'm particularly touched by your presentation, and the fact that you've engaged and also engaged. You've learned the cutting edge state of art technology, and also trying to implement it in African resource limited setting. And I feel particularly touched by it because this district hospital, like some sort of a resource limited setting, before later on working in the General Hospital, which was like the state of art as concerns radiology in Cameroon. In Bamayo, we had just simple radiology, just an X-ray, let's say an obsolete X-ray machine, but we could get images for which we could easily follow up our people. While in Yaoundé, we had the CT scan, and we had the CT scan. We had access to the CT scan, which is a 16 barrel, obsolete for its time, because I don't think you bear with me, 164 or 128 barracks now in order to have better diagnosis for the patient, because there are some lesions which you will not obviously pick up if you're having 16 barracks. I'm not want to go into that, but maybe you throw more light. But what was disgraceful for me working in the Yaoundé General Hospital was the fact that we had a CT scan got bad, and it took 6 months for it to be repaired. That's a referral hospital. We get bad, the CT scan gets bad, and it takes about 6 months for it to be repaired. So we had to be referring patients to go to clinics. I felt particularly ashamed one night when a patient was referred from the Betua District Hospital, Betua Regional Hospital for a stroke. He came to the hospital at midnight, and I had to send them to go to a clinic to do a CT scan at midnight. The look on the family's face, I could see I could see actually disappointment. And so the fact that you, my question to you is this: I see you've engaged a lot with our leaders back home and the rest. What, how does it? Is there something which is put in place for the maintenance and for the training of the people? Because it doesn't suffice getting all of this equipment. What does it take into place? The Plan National d'Urgence. It doesn't suffice us getting equipment. If we get the equipment, within 6 months they'll get bad and they'll stay for 10 years without it being fixed. Truth is, there's an MRI scan. There's an MRI in the CSU. I remember it was bought when I was in 4th year. It got bad about 6 months later. I don't know if there's any MRI in CSU after that.
Yeah, so I also wanted to adjourn to that the MRI in CSU got bad till date. I think I was still a fellow. I was a fellow in Cameroon. So it's almost 11 years it has not been fixed. So just adding to that, yeah.
And so that's my first worry. And the second worry is this: someone sent a direct one document to me about 3 days ago, which has the contacts of radiologists in Cameroon, of all medical specialties in Cameroon. And I was really happy to see we have about almost 100 radiologists in Cameroon, which is quite interesting. But the bulk of them are concentrated in Yaoundé and Douala, like it's always the case for all other specialties. How do we use the access of telemedicine to make sure we could? Is there some possibility of us maybe getting these different connecting doctors and technicians in such a way that someone could get an X-ray and send it to a radiologist maybe in Yaoundé or something, and it interprets and sends it back to the doctor with the respect of obviously the medical secret, not making sure people's images are sent to some public forum and the rest. Thank you.
So,
hello?
Yes.
Yeah, those were my questions. Yeah, thanks.
Thank you so much for your question, and Dr. Kennedy will be here to answer your question.
Thank you so much for those questions. Those are really very insightful questions. The first question you asked was about CT scans and the turnover, the downtime, right? You had 6 months for getting your machine to work, and you talked about maintenance and some of the problems that we talked about. To me, that's one of the biggest issues. I always tell people sometimes we have an epidemic of equipment failure, right? Most of the equipments don't work. And the thing is this, right? I think the burden of sort of lies on two parties. I think the vendors that sell these machines, like Siemens and other companies, there are a bunch of them that sell these machines. I think when you're negotiating that vendor contract, it's very important to see that you make sure that you have some kind of warranty in that contract. You have something that would at least keep the machine working for a year, and then you have some kind of maintenance. That being said, I think that the public sector, right, the government should also insist that these companies that sell equipment to us have provisions to help train our local people on how to troubleshoot these machines, right? So I know that when it comes to things like research and development, I know this is a very tricky topic, but when it comes to contracts like this, some countries like China and other countries insist that if you bring a device and you're selling in their country, you have to train some of the local folks on how to sustain this equipment. So that's something that I think that the arm of the government has to come strong on some of these vendors and make sure that they provide that training that we need to have local engineers that are able to decrease downtime, right? And then it's important that these hospitals also have some kind of maintenance in place. They should have a plan for when an equipment breaks down, right? I've heard of cases where just a simple fuse breaks in the machine and nobody can fix it, and the machine is down for 6 months. You have a machine, take for instance, God forbid you have an MRI scan that costs anywhere from $1.2 million to $2.2 million lying down, just a small fuse that could change. So you've had these stories that it's a horror story. So you want to have that relationship that the vendors have some kind of contractor obligation to sustain this equipment. I think that is something that we don't really emphasize in our contract, but this is something that has been talked about how to negotiate these contracts and make sure that the vendors are intimately part of the whole process. And to a certain extent, I think that one of the things we saw with Mingo is that they worked with somebody that had a local person that was able to work side by side with them and sort of help them in case there were some kind of equipment breakdown. All right. The second thing you talked about was the fact that imaging is concentrated in Yaoundé, in the big cities, and does telemedicine play a role in helping to help with some of the disparities, right, with the rural areas, helping to provide access to imaging in rural areas? The simple answer is yes, right? But the first thing is we need to get telemedicine, right? We need to be able to put the capacity on the machine, well, capacity in terms of adding that component that would create a digital image, and that image can be sent anywhere in the world, right? So I think that's really critical, right? So if you have, I think the government could come up with a strategy where you for every local or rural hospital, you have some telemedicine component, because I think that's important. Everything is changing, right? I remember living from Cameroon, we just had phones. Now everybody has internet on their phone. So you could really transmit, you could do a lot with this new society. This is the digital, this is the internet era, and internet plays a role in how we treat patients. And I think that radiology really benefits from having a robust system that you can move images around. So yes, to answer your question simply, I think that would be a great idea.
Great, thank you. Etienne.
Okay, thank you very much for the presentation. Thank you to Dr. Former and everyone on board for contributing to at least this forum and making sure it's going on. Yeah, I'm Etienne. I'm based in Cameroon. I'm a physiotherapist, and I work at the Regional Hospital Bamenda at the moment. Yes, I think one of the major problems to all this machine is actually the power or energy source, electricity. And for all major equipments, actually, or appliances, that has actually been one of our major reasons for failure or breakdown. Like now, we are trying to make sure that we only do X-rays and other imaging, actually just using the generator, actually, not depending on a new any longer, because the low voltage, it keeps fluctuating so much, and has been actually causing a lot of problem with the imagery center, actually. So now we depend basically on the generator to whenever we put it on for given hours, I think about 4 hours in a row, then they do that, then they have a break, then they come back, then they take it in a row, just to make sure that the machines are there. Just to clear that in fact, as we experiencing that from this end, I think electrical energy is one of the major source. And it's true that the main problem in Cameroon is that we have no competitor. And if you have a sole proprietorship, there's a big, it becomes so difficult with no competitor, it becomes so difficult, especially when people don't really question about the quality of service they provide. Apart from that, I think I'm not a radiologist, but I just want to propose or say, at least if as we are moving forward and we are trying to put ideas to improve our system, it's important we also think of it in this light. Anyway, it's a subjective idea. So, but I think one of our major problem in Cameroon is management. It's true we have a lot of system barrier and there are some environmental factors, but all these, when you look at it, it's all tied to management to some point, because if we really review our system from time to time and look at areas where we can improve, then definitely we'll make a lot of improvement. And one thing with what the doctor was saying, yes, it's true, we can make contracts that when we buy, we make it obligatory that as they come to install the machines, they should try to train people on ground. But one thing that always baffle me is that in Cameroon, you don't see a lot of, like, you can say some competitive scholarship in an area where people can gain and then they come back home, for instance, maybe 5 years before you can leave or 5 years before you do this. But we don't have things like that, because if we now say we want to train, for instance, there are 5, 10 scholarship where medical student can go for that and then come back home, perhaps work for 10 years. If they want to renew the contract, they go otherwise, they can leave and things like that. I mean, I think the Presbyterians are doing it, or Presbyterians or the Baptists are doing it, where they train specialists abroad and then they come, they work for a series of time and then they allow them. Because if we have people who are trained and we say, okay, when you supply us a machine, yes, you work with our clinicians on ground for this length of time, it's okay. But when you have people that are trained for 2 weeks, a month, and they get used to different brands of machines that they've never been used to. For instance, you're talking about different imaging quality of machine that can produce different. Yes, they bring the first one, they are on ground, they see it. Then they bring the second one, they don't know it, or they are just familiar with certain things. But people who are trained and they understand the system of some of these things, definitely if it's just a few or some minor things, they can do it. So I think our management system, and I think that is one of the areas where I think this forum should be thinking of how to, why we're thinking of how to connect people, or how to bring more machines, or how to help some of these organizations. We should be really thinking of how we can sustain the system and make it at least, this guy said, there are certain things that we can address just by reasoning very logically. They said we actually lack a minister of common sense in our cabinet. That's why because like one put it, African problem in Africa defy all logics, because we have everything, but yet we are still suffering. So I think we should really try and also think of this systemic changes that we can instill in us. I know we are doing it, but let's keep on pushing hard and then look at ways of how to really bring about some sustained change, for instance, through maybe scholarship, through this networking and things like that. Thank you very much.
So I wanted to address this, the issue of power and energy. So I've been at conferences where this is talked about, and I mean, the idea is that at the end of the day, you really ideally you want to have some of those equipment are made for certain economies, right? The Siemens designs these machines for Germany and the US, and there they have stable power. So nobody thinks about, making sure that they don't usually adapt those components to our own climate or our own environment. But some people have suggested that when you make these images, this technology should be designed in Africa, and sometimes we would make an image. The goal is to be able to get equipment that is more resistant to alterations in power, and those are conversations that have been had. So you sort of want some of these companies to invest in things that have been that would benefit our environment. But at the same time, most of these companies are driven by money, right? So they will not, typically our unfortunately we don't purchase those equipment, so they have no incentive to market to us and make changes that would feed us. So that's where the economy becomes important. Like, how do you, because if you have buying power, like some countries do, they'll be able to put pressure on some of these companies to, or it's sort of at a fundamental level, it sort of comes down to being, if you can do it yourself, then you wouldn't need help, right? But at the same time, if you're relying on other people, they'll give you what they have. And so you definitely want some of these companies to create devices that are more resistant to failures like this, because they have no incentive at the moment to do this. And then we also have to address the issues of power on our end, right? So just like you said, you mentioned that there was a generator that you use for your X-ray machine. there's some creative solutions that you can use to help you manage the fluctuations in power. And, so it's up to us to sort of look at ways to come up with creative solutions to help with the power issue. And if I remember correctly, another question about management, I'll be honest with you, that's something I'm not particularly, but management is an issue. I know we have issues with leadership. I don't want to go into that. That becomes really, really political, but we just have to adjust our priorities. Sometimes I'll go to Cameroon and there'll be a hospital without an ultrasound machine. And then, the person that runs the hospital has a couple of Prados, and I'm like, you could sell those cars and buy ultrasound machines, but your priorities are different. So you have to adjust your priorities and make sure that we really have good priorities when it comes to healthcare.
Thank you so much, Agbo. If not, we can go to Dr. Muno. Your hand has been up.
Yeah. So I just wanted to highlight some of the things you said during your presentations that really struck me, is the fact that we do, at the moment related to my field, we really could actually harness knowledge from abroad and actually transfer it to Africa. In the case of Tanzania, you guys did, trained interventional radiologists, and that was feasible, and it was made in such a way, you guys did it in a way which was very local. And my question would be, have you thought about us doing this in Cameroon? We have radiologists in Cameroon, but from my knowledge, even among the 100 radiologists, there is no one who is doing interventional radiology. There may be people who have been trained in the past in France and have forgotten, because I know maybe one or two who were trained, but there is no one practicing interventional radiology in Cameroon. And in the field of oncology, you would never get to see cancers and even diagnose them if you're unable to get tissue safely from these patients. And from all what we know is that the best person to get a tissue for you to be able to say you do have cancer is to get an interventional radiology. Without that, we're even going to get into a position where we're going to think most of these problems are not even existing in the first place. Cameroonians drink a lot. A lot of people do have liver issues. A lot of them develop liver cancers. I know a lot of family members who died of liver cancer, not direct, but friends, parents, and everybody. But nobody talks about things like that. Hepatitis level in Cameroon is extremely high, with a lot of people developing cancers that no one has ever biopsied. So we are unable to even classify what is the prevalence of hepatocellular carcinoma in Cameroon. The criteria is using an MRI, as we said, in CSU when I was there, they bought an MRI, were so happy. I don't know exactly how they got it, but in a year, it got bad, and for 11 years, it has not been fixed. There's just one MRI in Yaoundé, and that's in the military hospital. And it gets to the point where my question is, can you use the same model and be able to train Cameroonians in the model? And what are the difficulties that you feel we could face by using this model? Because I know we are French speaking and it comes with a lot of, the majority is French speaking, but I know medicine is in English. It comes with a lot of loopholes, just trying to get people who get others to understand. My second point is addressing the issue more of, a lot of people have asked, is how sustainable, can Cameroon afford this? And I don't want us to get into the poor man's mentality. And I think health for all is truly what the government needs to take into consideration and provide healthcare insurance. And the government spends money on so many other things, and these are all sustainable things. If our government can provide dialysis, though it's not perfect for every patient in Cameroon, they can provide imaging. And I think they started it, and they can subsidize imaging. And as you said, this was something I knew only when I moved here. There are just so many people involved in good imaging. Like in my oncology center, a rad oncologist, you need the physicists, you need people who are technicians, you need dosimetrists. We don't ever think about training those kind of people, the auxiliary staff. We think about, okay, let's go train doctors. No, doctors cannot work alone. There are people who are even more important than the doctors that need to be trained in order for you to be able to do of these interventions that we do lack. So that's just sustainability is really a big issue, but let me leave it there, Kennedy, and then maybe you can respond to some of my questions.
Yeah, so thank you so much. Obviously, you know, the questions are so good, and I mean, I think about that all the time, right? So, I mean, to be very clear, very positive with you, I'm hoping that it's something that we can do in Cameroon. I mean, you know, it's not always. Sometimes you need to have certain things to align for you to be able to do some of these projects, and then there's some red tapes that you have to go, have to cut to be able to do this. But I think that it's possible. I honestly think it's possible. I would always want to preface this by saying that when people talk about interventional radiology, that term is used very loosely, but the whole full spectrum of interventional radiology is really broad. And, you can talk about doing very complex things like trying to, doing interventional oncology and trying to treat tumors with chemoembolization and doing very, certain things. And then, you have the low end thing of just doing abscess drainage using CT scan. So, I mean, that spectrum is very broad, but at the same time, somebody could, most general radiologists are trained to be able to do light procedures, but then when you get into the more complex procedures, then you need somebody who's a little bit more trained. So, but unfortunately in Cameroon, you don't always get the full picture, right? People will tell you that they have some training, but they don't really always, unfortunately, it's not always true, right? Sometimes they're just, it's not true. They don't have the full training. So it's not easy way to verify that information. Sometimes, in most societies, you hope that you can have some kind of a professional organization that can, have, something like accreditation and, things like that can protect the, we don't have that in Cameroon. So it's very difficult to be able to assess the type of skilled force we have. But, I think that the avenues that we can, discuss about and sort of try to repeat some of the things that have worked in other places. Obviously, it's not always going to be the same, but you need the people on the soil to be receptive to some of these things. Obviously, it's not, you're just collaborating, right? You're trying to transfer knowledge and share ideas. That's the goal. It's not, we don't want to change anything, but just want to make sure that you can share ideas and get things better. So that's the approach that I think that we should be taking. But I'll tell you that it's easier said than done. And then I know you asked a question about what was the next thing? I forget. You talked about just teamwork in general and how you need to train. Capacity building is so important. People don't know that. That's one thing that was good about RAD is that they did this readiness assessment. And for you to typically you don't want to have an MRI scan when you don't need the imaging, right? You cannot say that you cannot have a CT scan when you don't actually treat. If you say you're imaging people's heads, I guess you should have some kind of TPA in case they have a stroke. You don't want to have unnecessary imaging. So sometimes some people acquire, we don't always get the best allocation of resources. So that's something else that we need to work on. That's why that imaging readiness assessment is important. You want to make sure that they have the components that are necessary. You want to make sure that, radiology is a team sport. That's what I always tell people. We rely on the surgeons rely on us. So it's a team sport. I mean, in very rare cases, you can help this. You can do something called work shift, task shifting, where some of the other doctors can be trained to be able to do some of the interpretations by themselves. But when you come to very sophisticated imaging, that's not always possible. It's just difficult for you to achieve that. So I don't know. I think that in ideally, for you always have to address things in a systemic fashion, which is not it's not easy. But going back to your first question, yes, it's definitely possible that we could replicate some of those things we had done in Tanzania and Cameroon. Yes.
Okay, thank you very much. And I hear this question, of course, coming over and over. And I think you had mentioned in your presentation that the private sector is coming up seriously to invest in this sector of radiology. And one of the ways government can always do this is to also give tax incentive to ensure that all entrepreneurs who want to invest in radiology, first of all, the equipment is expensive. And so if you can have free custom importation duties for those equipment, that could be one step up. But what about just making the tax-free services for their operations in the country? And why not also just giving them some subsidies just like education. Education is important. When you open a primary school in Cameroon, you don't pay taxes because you see these are essential services. So why should someone who imports an MRI and is operating it at private level pay taxes as well? So some of those tax incentives can also drive the private sector to come in to close the gap. And I think when you look at the complexity of setting up an entirely sustainable and functional imaging center, do you think the private sector has the capacity to close this gap?
I'll say that that yes. I mean, you need everybody. I think the private sector is becoming even more important. The thing with the public sector is that the government is that safety net you want to have, and we've talked about cost, right? When it comes to cost of imaging, I think that sometimes the public sector, the government sometimes provides more competitive prices, and so, but at the same time, you need more access, and the private sector fills the gap when it comes to access. There's something I would like to talk about, which when it comes to sort of importing equipment into Cameroon. I've seen and I've spoken to people who have brought machines and other devices into Cameroon, and you typically notice that it's not always the case that everything goes through, not everything is declared at customs, and it's good and bad. We have some vendors that are doing it through certain channels and they do what they have to do, but I think it's always important to sort of consult with a local person that, like engineer that has knowledge of that equipment, because sometimes you can buy an equipment and then the equipment is the parts are not being made anymore. And if something happens, you cannot get the parts. You can call the company, they stop making the parts. That's information you want to know, right? So that's some of this information you can actually get somebody who is more savvy in that sense to sort of take the number, the identification number of that machine and run it through the database to see if the machine is still being made or if the parts are being made in case something were to happen. I've heard stories where people are not able to fix the equipment because they cannot find the parts, and then but that also speaks to the fact that sometimes we have imaging just coming out of anywhere, and this equipment, when they get bad, You don't have any. You cannot trace where it's. So it's just we need a more organized system. I would say that you need to have a system that the engineering component is so important. I cannot explain that to you, but if you're going to spend a lot of money, I think it's important to have somebody that knows a little bit about imaging to help you make those decisions, because you don't want to have an equipment sitting there not functioning and then you cannot fix it because you don't have the parts.
Okay, thank you, Doc, for those responses. Now we're going to take Dr. Ojong. I see his hand has been up for a while. Dr. Ojong, over to you.
Thank you, Dr. Allison, for giving me the floor. I'm grateful to me. Striking me a little bit. What I catch has been very edifying. I have one question and then I have a comment, and I want to also have your opinion on my comment. With respect to my question, I want to know how important safety, biosafety, and waste disposal are when talking generally about radiology. And do you think from being in the corridors of radiology, we give that enough importance in our healthcare system, in our hospitals? Do we give enough attention to biosafety and to waste disposal? Do we have what it takes to handle radiological waste back home? That's my question. And then my comment, I'm a little bit embarrassed, to say the least, when I get us describing the multiple plagues radiology suffering from in Cameroon. Embarrassed because, and now I'm not going to attack the government, it's very cheap to do that. Every health system, every country is basically one of three things: either the survival phase, the thrive phase, or the transform phase. And in my opinion, Cameroon is a typical survival system, which is being like, we are deceived by the proliferation of, in quotes, quote unquote, tertiary hospitals, which give us the impression that we are having either a thriving or a transforming health system. We have a surviving health system. And radiology is one of those specialties where you can't cheat. If the health system isn't robust and solid, you can graft sustainable radiology onto it. I am even a little more embarrassed with in thinking that we could easily imitate what has been done in Tanzania. It's a health system which I understand. It will really be wishful thinking to try to adopt the same thing. Additionally, I was a bit attracted by the comment with respect to the private sector. I'm one of those who think that the private sector is muddying the waters as far as radiology is concerned, because I think there's a very big difference between having MRI services in the town and having an MRI machine. I've seen situations where patients have paid for MRIs, and then later on we have to ask for a CT scan because there was no one to interpret the MRI. And it's not isolated, it is actually super frequent. And I don't think right now, as much as we want it, we can barely afford adequate basic radiology. I don't think there is place to invest in more sophisticated radiology or interventional radiology. I mean, we need it, but I don't think the health system is ready enough for it. So that's my comment as far as that is concerned. And then my question, I want to get your opinion, Dr. Foyong. Thank you.
Dr. Foyong, please take it over.
Yeah, thank you so much for those comments and for that question. I would say that you know what, I see where you're coming from, and I try a lot not to, you know, it's very difficult, right? You want to be as optimistic as you can be, but sometimes reality hits you in the face, and you know, it's, yeah, I think some of what we do is wishful thinking. I agree with you, but you know, you have to start from somewhere. You have to try. You know, I'd say that yeah, the private sector, we need a private sector. You need that competition to drive down prices. You know, you also need the public sector. I think they play different roles. I think both are important. We have problems, right? We know we have problems. We don't have the capacity, and we need to build that capacity. And however we can do it, we have to come up. It's, you know, I ask for advice all the time on what to do to help build capacity. It's just this a need, and we cannot meet that need at the moment. You talked about safety, right? Radiology safety, waste disposal, biosafety. I mean, this is a whole topic on itself, and I'll say that safety in radiology is critical, right? You know, X-ray is not completely benign. It has some, you know, you have to be careful. You know, when we use, you know, different, when we use, you know, when we get biomarkers and we use nuclear imaging modalities and we use certain things, they have radiation, and radiation is not always benign. So, you know, the goal is that you want to build a system where your safety becomes priority, where you have things that you can do to ensure that you have a safe environment, because the person delivering the X-ray should be protected from the X-ray, and you know, you have to build, you know, a Faraday cage, whatever you need to build to protect the person from getting X-rays. So that has to be part of the installation of the equipment. That comes from, you have to look at safety. Safety is critical for you to even have the imaging center. As far as waste disposal is concerned, I don't think we are there yet. We don't even have the things to dispose. So I wouldn't say that we have the waste to dispose, to be honest. We don't have. So yes, so we don't have the facilities yet for that. But I like the way you're thinking. I like the whole point about safety. I'm a big, when I go, even to do an MRI, you need to scan the patient, make sure they don't have metal. If they have some kind of metal in their body, you can have really bad things happen, right? So that is something that you have to train. That's part of capacity building. We have to go in there and tell, you know, the technologists to make sure that before you send this patient an MRI scan, this is a magnet. It's very high, very strong magnet. Make sure they don't have metal in their body, because it's going to rip it off. It's going to burn. You know, things are going to happen. So that's part of the training. That's part of the capacity building, and that's what we sort of, you hope that you can get an imaging center to understand.
Thank you, Doc. So I think before we take the next question, let's just give Dr. Foyong a few seconds so he can breathe. We've just been bombarding him with questions from all angles. We're just going to check the temperature in the house with a few of our viewers who've logged in. And I'm just going to call on Dr. Ivo Zita. I see he's seriously typing. Doc, how are you doing this weekend?
Oh my goodness. I'm so sorry. I'm on call and I'm scoping patients here in the hospital. But I've been following up the discussions. from time to time. That's why I'm not in a position to ask questions right now, but I'm right in the hospital.
No,
Dr.
we are happy to
of
see
course.
you multitasking and joining us despite it's such a pleasure.
I know, thank you. And I wanted to make a comment. Kennedy, thank you so much for this wonderful presentation. I think I've personally benefited from your knowledge, especially back home, where I've had patients go to Mbingo and I've had CT scans done, and I've contacted you here in the US, and you immediately reached out to Mbingo to ask for the details of the patient, and you were able to pull up the imaging and read it right here for me. So, guys, you've got a great opportunity here, a great resource, and do not hesitate. Get to him. As the other guys have said, he is a wonderful person. He doesn't hesitate. He's going to look into stuff and will, in a timely fashion, answer your questions and allow you to be able to move forward with whatever plans you have. So, thank you, guys. Hopefully, I shouldn't be on call for the next 2 months, so I should be able to attend more of this, and I'll be able to follow up the discussions in detail and ask more informed questions. But thank you, guys.
Thank you, Doc. And sorry for putting you on the spot.
No, it's okay. It's okay.
All right, we're going to just call on one more person who's going to tell us about how she sees the temperature in the house. Joyce Poyong, we see you're online. Would you want to please unmute yourself and just tell us how you're seeing these discussions? Joyce? Joyce Poyong? Okay, maybe Joyce might not be in a position to unmute herself. Oh, there you go.
I'm so sorry, Alison.
Hi, Joyce.
Hi, everybody. I've been trying to follow up the discussion while multitasking as well.
Mm-hmm.
I hope you don't mind if you hear the baby cry at the background at some point, but
we don't mind at all.
Yeah, but I've listened to the discussion and it's been really insightful. I'm excited about the prospects of us linking up with this kind of knowledge and making out a lot of things from it. And I'd like to ask a question. I hope it's not being asked because I'm going in and out. I don't know. I'll ask this question to Kennedy, really. Dr. Foyle, I was wondering how possible it is for you to personally maybe link up with the faculties in Cameroon and coordinate like a residency program in radiology or just be part of it. Is that something you're looking at? Is that something you're thinking about? Thank you.
Thank you, Joyce, for that contribution. You see, I'm so glad I picked on you, and sorry for putting you on the spot. As for babies, we have many town hall babies. It's always such a pleasure. Babies are welcome. We can see Dr. Ayuk Former with her baby. We have many of our participants who join with their babies, and it's such a pleasure to see them, to see the future of tomorrow. Maybe before I give the floor to Dr. Foyon, I'm going to pick on Dr. Brunhilda Santu. You know, she's always sitting and just listening, and you're wondering what is going on in her mind. Doc, how are you seeing the temperature in the house this weekend?
Well, very hot. Well, thank you, Dr. Kennedy, for that very interesting and great insight. I actually don't have a whole lot more to say, but you know, I'll always chip in some COVID knowledge in it. When I think, was it Dr. Tegomo that asked about the importance of imaging with COVID? I actually fully agree with what Dr. Foyong said. It doesn't, I mean, it could help, but it doesn't have a whole lot of a big role. And I say this partly because during some of my interactions with colleagues back at home regarding treatment of patients, some were actually focused on getting x-rays for patients that are already so hypoxic. And I think logistically, even it would have been challenging for them to move these patients who are already saturating really low on high oxygen supplementation to go get an x-ray, which will not change the overall management. So if you have COVID patients and they're hypoxic because they have pneumonia. It is true that yes, they could have a PE, but generally it would not change your management. So it may help, but it's not absolutely necessary. And yes, I agree also that it could help with maybe follow up with complications, but in a setting where we have limitations, it shouldn't really be a priority for COVID in particular. Now, Dr. Foyong, I don't, or maybe someone else can answer this. Is there fluoroscopy in Cameroon? Probably, I mean, I'm not sure, but that was just a question that I had out there. And then to Dr. Former, yes, the oncologists actually work hand in hand with interventional radiologists a lot for diagnostics, and actually with pulmonologists as well. And we, for instance, we may have certain nodules that are not accessible via interventional radiology biopsy. And if these patients have lymphadenopathies or they have endobronchial lesions, we actually do procedures for biopsies. So, in some settings also, they have multidisciplinary settings where you have the oncologists, you have the radiation, you have the radiologists, you have pulmonologists, and some other physicians that come together to kind of collaborate. So yes, and I collaborate a lot with radiologists too. Even for some of we sometimes have some really critical patients who are too sick to undergo surgery, but then they could do drainage, IR drainage, and that really helps as well. So overall, it's been a very interesting and important topic. Unfortunately, we still have a lot of challenges back home, and that's probably where I don't know how we can solve that problem. But no knowledge is useless. Thank you.
Thank you, Dr. Santo. Always a pleasure listening to your interventions. And Dr. Foyong, as you're preparing to answer Joyce's question, I'm just going to add, what we've seen with previous speakers is that there is benefit when there is like an association of radiologists. Say we have a few radiologists of Cameroon origin, and they are based either here in the US or even like the whole of North America. So is there such an association that exists so that maybe people who are radiologists who are practicing back home or little groups of experts who are interested in this area can collaborate with you or liaise with you to further enhance or enrich their experience back home? So this is just to add to Joyce's question around the possibility of you collaborating with faculties of medicine back home to train radiologists. So that's an additional question. And, just to say, after Dr. Foyong takes that question, the person whose phone appears as MI11 Light, I'm sorry, I have not been able to get your full identity, but you're going to be next. Let's just give Dr. Foyong the chance to answer the questions he has so far. Dr. Foyong, over to you.
Right, thank you so much for those questions. Thank you, Joyce, for your question. You asked me about collaborations with faculty in Cameroon, right? I would say that most of the work we did in Tanzania was done through Frank Minja, and he was a radiologist at Yale, and he had a tremendous working relationship with the hospital, the main hospital in Tanzania, in Dar es Salaam, Muhimbili Hospital, and because of that, they were able to work together to advance their training program. Yeah, I know in Cameroon we have a radiology training program, which is great, and it's been existing for years, right? And I think they graduate about 3 residents per year. And typically, the goal for us is always it's always good to align with the training program, because we always believe that the best way to spread knowledge is by lining up with the training program, so that you can teach one person and that information can be multiplied across multiple people. I think that's usually the most sustainable model to work in. So I mean, I'm always interested in opportunities to collaborate with that faculty to see if I can add some value to what they do already. So I would say that yes, that's something that I'm looking at or been looking at. All right, the second question was fluoroscopy. Dr. Santa asked about just the presence of fluoroscopy in Cameroon. I think that we have fluoroscopy in Cameroon. I've seen some fluoroscopy machines that do not work. I have pictures. So I know that maybe we have ones that work, but I think that there's fluoroscopy in Cameroon. And it's a useful modality. It uses X-ray, and we use it a lot. So I think that we have that in Cameroon. And then you talked about, I think the second question was about collaboration in healthcare. Me personally, I have benefited from, I work with other physicians, and I'm always, the most valuable conversations we have is with other doctors. I talk to a lot of neurologists, and they come to me with their patients, and we sort of go back and forth, and they tell me what they are seeing on the clinical side. I tell them what I'm seeing on the imaging side. I think that is the best thing for the patient. You get the best outcomes from that kind of collaboration. So collaborations are very important in healthcare. And then you talked about associations in radiology. I've been to some national meetings in Cameroon, and I know that there is an organization. I think that there may be an organization. I would have to say that I'm not fully aware of the organization. I'm not a member, so I don't really know if there's a real organization. But I'm a big proponent of having an organization, an association of radiologists in Cameroon, having a group of professionals. And I think that's very important to be able to quality control what we do, right? And to protect the public. We cannot. It's important that you have an organization that evaluates your peers. You want to have that peer-to-peer evaluation and make sure that we don't have people practicing dangerous medicine. And I'll be honest with you, the type of reads you get from radiology are so variable. And to be honest with you, there's certain things I will not even look at. But and I'm speaking from, yeah, so it's not always, the truth is you don't always get, there's so much variability. So I think that having quality control, having accreditation, having certification, having professional organizations that have a role to keep the standards of care is very important for our patients.
Thank you, Dr. Foyong. We're going to take the next set of questions, which hopefully is going to be the last as we are getting ready to round up. M11 light. I'm not sure who has logged in with the phone. MI11 light. Yeah,
it's me.
You have the floor. Hello.
It's Dr. Wingo right here.
Dr. Ringo, so good to have you. I'm so sorry. I've been trying to find the person behind this participant's ID. I'm so sorry. Please, Dr. Ringo, you have the floor. Please go ahead.
Thank you very much. I'm sorry I had to come into the hall this time around through the back door because of some logistics and connection issue. But thank God I'm here. I would like to thank Dr. Foyong for the very bright presentation and for really touching on the topic that is of great importance, not only to all the healthcare professionals, but even to the population. One thing that you must understand is that the population believes a lot in paraclinicals. Like if somebody gets to the hospital and does not get a paraclinical, they might not really be satisfied. And so most of them go for it. What I'm going to go straight to is the ultrasound. Now, one thing with the ultrasound is that everybody thinks they can do an ultrasound. I've had a hard time to reject results of ultrasounds that are done by somebody that is not a sonographer. My first question to Dr. Foyong is that what is your experience beyond medical doctors and radiologists? What is your experience with profans handling ultrasound in the communities? Because when you sit in the hospital as a medical practitioner, somebody just pops in with a result of ultrasound. And when you read the name of the person who did it, you can't even understand. It's either a nurse, it's either somebody who has just been trained. I would like to find out from you, is it a practice that you encourage? Could it be given added value, or is it something that we should totally discourage and try to work towards tracking down such people and bringing them to book and probably arresting some and locking them up? I will give you a very short experience that I had. Someone actually went with the child and did an ultrasound with somebody I couldn't really identify. And when they brought this result to me, I had to conduct a surgery on the child. I told the man that I couldn't operate your child based on this result, sir. And this man was very angry. He said, I am refusing to operate on his child simply because they went and did the ultrasound where I did not want them to do it. And therefore, I am simply being biased rather than focusing on the results that were given to me. I will not tell you what the results were saying, but it was horrible. This man went as far as publishing my name. He was a Muslim. So he published my name in front of the mosque, the central mosque in Bamenda, asking all the Muslims that don't go to this doctor. He is biased and he has refused to treat my patient. So what I'm asking you is from a personal experience that tells us that is there something we can do in the population to make sure that people who are not any close to medical practitioners do not venture? And I am talking about this with doctors in the house. Sometimes it is some of us that actually give this power to some people to be running ultrasounds and giving us very funny results. Thank you.
Thank you,
Thank you, Dr. Ringo, for that question. Dr. Foyong, maybe before you respond to Dr. Ringo, I just want to reiterate, which you probably know, that Dr. Ringo is one of our senior colleagues who wears more than 2 hats. So he's a clinician, but he's also into policy making. So some of these hot recommendations that are burning within you, fire them his way. Don't even hesitate, because we are having a scientific discussion, but we're also thinking about next steps and, getting things to change. So some of the hot recommendations that you're sitting, that policymakers need to hear, you can fire them his direction, because he could be an agent of change. Yeah, Dr. Foyong, over to you.
Yeah, I just want to say that, thank you, Dr. Wingo. I think that I don't know, it's very common. What you're telling me is so relatable. I can relate to that a lot. So ultrasound is one of those modalities which is highly operator dependent. It really depends on who does it. And, unfortunately, just like you said, the ultrasound is as good as who does it. So there's no standardization. If I can almost say that I would take CTs from anywhere, but ultrasound, no, I need to know exactly where it's coming from and who is doing it, because it's so operator dependent. Yeah, and I don't know. I think that when I went to Cameroon, I knew that there were 2 models of doing ultrasound. I know that in the US and usually we have something called a sonographer. That's a job description for a person that performs ultrasound, and they get some training after a bachelor's degree, and their job is to do just ultrasound. But then we have another model where you have the doctors themselves which will do the ultrasounds, and that's also a great model, right? They do that in a lot of European countries. That's done. But the bottom line is that ultrasound is one of those modalities where it's so operator dependent. It really depends on who does it, and you don't want to take information from everybody. And we have to really be careful as to who we get ultrasounds from. And that sort of brings back to my point of having some standardization, right? Some level of quality control when it comes to diagnosis. And diagnostic imaging in Cameroon we need to have I say that you need to have people that have some kind of certification doing this ultrasound, as opposed to just getting a random ultrasound from the middle of the market. And I won't trust some of those results.
Thank you, Dr. Foyong. Is there room for task shifting in case of, limited trained personnel?
Yeah, sorry, I have a comment here when Dr. Foyong is done. This is Dr. Dida. The question is a very technical question, and I'm glad that Dr. Wingo is the one asking this question, and he is also involved in policy making. Because Dr. Foyong out here, I'm not very sure how much he can really make a difference as when it comes to people making such reports in the community. But I think it's left to the policymakers, the stakeholders, to kind of decide for the community what we want. In a setting like ours, where we have a lot of limited resources, rather than perhaps just ask these folks to walk away, how can we instead harness or train these folks to be able to do what Dr. Foyong is saying? We have sonographers, at least not as trained as we may have in the US, but be able to provide some minimum quality results that we can at least make decisions on. Because I'll tell you what, we all know where we come from. We do not have access to a lot of resources. And sometimes something is better than nothing. So rather than perhaps, catch them, lock them, ask them never to, can we come up with a kind of a system where these people are instead trained, at least to get some basic knowledge and function as, in quotes, sonographers? That's my comment.
Right, thank you so much for that comment. I mean, ultrasound is, I don't know. I think that is so, what he said was just, just like I said, I relate so much to that. I've had a lot of people come to me for a second opinion, and I just look at what they had before, and I know, it's not correct. So I don't know. I think that you have to create the systems that work, right? So, how do you, can the government, I don't know, publish a list of people that have the best quality that you can go to, and these are centers of excellence? I'm not sure. Institutions, can there, it's really teamwork. It has to do with the institutions, the government, the facilities. It really comes down to creating those systems that work, right? Being able to make sure people don't game the system, because it's dangerous, right? When you tell somebody they have a finding and then they don't have it, or somebody, we go and tell you have a thyroid mass or something, just make an ultrasound diagnosis, and it's not correct, because that the cost of healthcare goes up. You spend more money chasing your tail, and you cannot find anything. So I say that it's sort of working. And I think this should be attacked from a systemic point of view, and making sure that we have centers where people can get reputable places where people can get reliable information, which is accurate.
Okay, thank you, Dr. Foyong. We're going to take one last question from Haggai. Haggai, are you there? Achumbom Haggai. Okay, maybe Haggai's questions have already been answered, because we did notice that Haggai's hand was up for a while. Maybe their questions have been answered already. All right, we're drawing close to the end. And Dr. Foyong, maybe before we give you the opportunity to give us your last closing thoughts of wisdom, we're just going to check in with all our co-moderators to see if they have any last remarks. Brian, do you have any final remarks regarding today's session?
I think it was a very fruitful session. I enjoyed the exchange, learned a lot. Thanks a lot, everyone.
Thank you, Brian. Christelle, est-ce que vous avez des derniers mots à nous donner, à nous dire?
Merci Alison, merci à chacun. C'était, pour ma part, je dirais merci au Dr. Kennedy. C'était très intéressant aussi les discussions sur comment faire pour améliorer la plateforme diagnostique, notamment la paraclinique dans notre contexte. Merci à tout le monde et au plaisir de revoir chacun à la prochaine édition. Merci Alison, merci Chairman et Elvis.
Merci beaucoup Christelle. Et pour nos téléspectateurs qui s'expriment mieux en français, n'hésitez pas à nous contacter si vous avez des difficultés à suivre nos émissions. Elvis, please, do you have any last comments for our viewers, for our presenter? Elvis, you're muted. Sorry.
Okay. Thank you very much, Alison, and thank you, Dr. Kennedy, for a very wonderful presentation. I would say that I've not seen a man who is so humble and try to be very nice, even when there is something that is so hot. I would expect him to say it. And he tries to be so nice, and he's been really, really nice. I had one of the most nicest part of him was when he was asked about fluoroscopy in Cameroon. He says, the equipment are there, even though I have not seen the one that works. That is so nice to handle this kind of very complex topics. And you've really been amazing in the way you delve through the really complex questions that were asked. And we've learned a lot from you today. I would just want to take a little time to do a resume of what we have had as conversation. So Dr. Foyong told us from the beginning that radiology involves using imaging to diagnose and treat disease. And he explained the two platforms or modalities that exist, the simple modality that has to do with X-ray and sonography. Then he talked about, the advanced modality that deals with other complex diagnoses like a CT scan. And expanding a little bit on the complex modality, he said this is mostly involved with situations like handling trauma and oncology and also other complex surgical care. And checking with Muno, who is an oncologist, Muno said something that was interesting. He said, where there is no tissue, there is no issue, which really comes to cancer diagnosis. Without imaging, we cannot be able to diagnose or even stage some cancers. So that was just to bring into context the importance of imaging. Imaging forms an integral part of making a healthcare delivery system efficient. And we were trying to just look about the situation in Cameroon, and we saw that available data shows that we have about 100 to 150 imaging centers in Cameroon, though most of them are centered in the major cities of Yaoundé and Douala. And most of them are only the basic modalities. And concerning advanced modalities, we saw that the private sector is coming up close to close the gap with about 6 of CT scan in Douala and 6 in Yaoundé. And we also heard about the government project called Plan d'Urgence that is aimed at providing more imaging centers around the country, though there is still some disparity in the way they allocate these resources following the geographical health map of Cameroon. Most of the equipments do not function at capacity, talking about the existing equipment, and this is because of limited maintenance. Most often people are flown from abroad to come service this equipment. We have just about 1 radiologist to about 300,000 patients in Cameroon, and 1 interventional radiologist to about 5 million inhabitants. This is really, really huge when it comes to the patient-doctor ratio. And there is also a big human resource limitation in the country. But of course, Kennedy wanted to paint a picture of other work that he's doing with an NGO called Red Aid, which is a nonprofit in the US that has volunteers and people who support this work by going to resource limited area. They look at the healthcare system. They use a radiology readiness assessment process and give guidance to a health system on what they need to do to become sustainable in radiology, and also help them to fill gaps where those gaps exist. And this range from things like maybe looking at IT, looking at power, looking at human resources. And we heard testimony of how Kennedy helped Bingo to define their strategy on how to set up their own radiology center, building it from scratch and obtaining even a 6-slide CT scanner and other imaging equipment through a loan, which he believes has been paid off already. And they also use teleradiology to help interpret images from distance, and also to use it as a way of training their local experts. And he also cited one of his collaborators, Dr. Ghislaine, whom he helped in training. But of course, Bingo had to solve this problem of equipment breaking down by making sure that they had their own engineer that is home-based. And this was about, he cited Dr. Roger Nana, that was there to be able to fix these equipments when they break. We heard of the Plan d'Urgence a little bit with some details, and he said there is intention to construct about 8 new hospitals and revamp about 3 existing ones. And this brings more equipment into the system. But of course, there is also plan to train technologists and that will be able to run this equipment. A high-field MRR was placed in the military hospital and it's still there right now, and the capacity building process is taking place to make sure that volunteers from Canada are able to come and provide some training. And of course, though COVID-19 brought some challenges to this project, we hope that it is still ongoing and might be just a step ahead to the process of revamping medical radiology in Cameroon. But then Dr. Foyong took us to Canada to share some experience about the work he did in Canada. He did some work in the country that at that time had no interventional radiologists. They chose the first 3 students and tried to train them in this program. And interventional radiologists from the US had to travel to Tanzania sequentially through mission trips to train these residents in Tanzania. And lectures from Yale were streamed online as part of the ways of providing distant education to train these interventional radiologists. And in September 2021, Tanzania was able to graduate the first 3 interventional radiologists. So this is a great success story we heard from him. So imaging is changing and we have to change our mindset of infectious disease or looking just as infectious disease, but also try to look at the spectrum of healthcare and looking at more complex illnesses. We suffer from high rates of equipment failures in Africa for those areas that we already have this equipment. And we heard of testimony from Carson of a time when he practiced in Cameroon that it took about 6 months to get a CT scan repaired, and about 11 years for an MRI that has not been able to be fixed in Seashu. These are all stories about the situation of diagnostic radiology in Cameroon. But of course, looking at the way forward, there is need to train a skilled workforce that will be able to improve on the situation of radiology in the country, not just training interventional radiologists, but looking at also training auxiliary staff that will be able to support the complete process of radiology. Vendors should also help to train local folks on how to sustain these equipments, because you know, if we do not arrange and sign good contracts, sales agreements with vendors, then we would always have equipments that we buy, and when they break down, we are not able to fix them. We just dive a little bit to talk about ultrasound, and I wanted to end my summary by this statement that your ultrasound is as good as he who does it. It's very interesting, and that was because Dr. Wingo cited the problem of having, you know, mediocres who do all sorts of ultrasound. That poses a very great problem as far as diagnosis is concerned. To succeed in this journey, there is need for standardization of diagnostics and imaging in Cameroon. This can be done through maybe having some professional organization that will be able to coordinate these efforts. Thank you so much, Dr. Kennedy. This was a bit I was able to capture, and maybe some last words from you before we say goodbye.
Thank you so much, Elvis. It was a pleasure. I'm so happy that we were able to spend some time, and you know, I just go back to where we met with Muno, and you know, we go back from way back, but it's come full circle that, you know, you're in a position where you can sort of discuss with some, you know, your peers now and try to help each other to see how you can contribute in helping and to fix some of our problems back home. But overall, I'm really, you know, just excited. I think the questions were so insightful. Some of the questions I got were some of the questions I've been asking myself. So I want to say that overall, I think that, you know, there's a positive, well, I mean, there are challenges in Cameroon, don't get me wrong, but, you know, there's always avenues where we can improve, and we shouldn't completely lose hope. So thank you all very much.
Thank you so much, and we are coming to the end of the presentation. We look forward to see you again next week.